In 2004, a landmark study was published in The Lancet that I believe every adult on the planet should know about. It was called the INTERHEART Study. 52 countries, over 29,000 participants, every major ethnic group and region of the world. And the question they set out to answer was deceptively simple. What actually causes heart attacks? Not theories, not models. Real people who had real heart attacks, and what those people had in common. What they found should have changed medicine permanently. They identified 9 modifiable risk factors, 9 things we can actually change. That together accounted for over 90% of the risk of a first heart attack globally. Across every population, every age group, men and women, the same 9 things. Over 90% of risk explained by factors within our control. And yet cardiovascular disease remains the #1 cause of death in the world every single year. My name is Dr. Victor Hayes. This topic is personal for me because cardiovascular disease has affected people I love, and it is the disease I see most frequently in the consequences of preventable deterioration. Let me walk you through those 9 factors, and then explain why knowing them has not been enough. Factor number 1 is abnormal lipids, specifically a high ratio of apolipoprotein B to apolipoprotein A1. Think of this as your atherogenic particle count relative to your protective cholesterol. This single factor alone accounted for nearly half of the attributable risk in the study. Half. Most people have never had a proper lipid profile done. They do not know their ApoB. They are walking around completely unaware that the single most powerful cardiovascular risk factor they carry has never been measured. Factor number 2 is smoking. Current smokers in the INTERHEART data had nearly 3 times the heart attack risk of non-smokers. 3 times. Smoking causes direct, immediate damage to the endothelium, the inner lining of your blood vessels. Every cigarette is an active insult to your cardiovascular system, not a slow background risk. The risk reduction from quitting begins almost immediately after stopping. Factor number 3 is hypertension, high blood pressure. This is the one that concerns me most from a clinical perspective because for most people it produces absolutely no symptoms. You can have dangerously elevated blood pressure and feel completely normal. Meanwhile, your arterial walls are stiffening, your heart is working against a pressure load it was never designed to sustain, and damage is accumulating continuously. In most countries, millions of people have undiagnosed hypertension right now. A blood pressure check takes 2 minutes, and a home monitor costs very little. Most people have never used one. Factor number 4 is diabetes. More specifically, the cardiovascular consequences of chronically dysregulated blood sugar. Persistently elevated glucose damages the endothelium, promotes systemic inflammation, and accelerates atherosclerosis through well-established mechanisms. And like hypertension, early metabolic dysfunction is largely silent. The damage is accumulating years before any diagnosis appears. Factor number 5 is abdominal obesity, and the study used waist-to-hip ratio rather than BMI, because it is not overall body weight that drives cardiovascular risk. It is visceral fat. The fat that accumulates around your organs is metabolically active. It drives systemic inflammation. It disrupts lipid metabolism. It promotes a proclotting state. It is not inert tissue sitting passively. It is actively driving disease processes. Factor number 6 surprises most people: psychosocial factors, chronic stress and depression. In the INTERHEART data, psychological stress was independently associated with heart attack risk. That word independently means that when every other risk factor was controlled for, psychological stress still showed up as a significant contributor. Your mental and emotional state is literally a cardiovascular variable. This is not wellness language. This is what the evidence shows. Factor number 7 is low fruit and vegetable consumption. Regular consumption was protective. Low consumption was associated with meaningfully higher risk. Not complicated, not expensive, just consistently absent from too many people's diets. Factor number 8 is physical inactivity. Regular physical activity was independently protective across every population in the study, and the threshold for benefit is lower than most people assume. Not elite training, not marathons or triathlons. Regular, moderate, consistent movement throughout the day. Factor number 9 is alcohol. The original INTERHEART data showed a modest association for moderate consumption, but the evidence has shifted substantially since 2004. A large Lancet analysis in 2018 concluded that when all health outcomes, including cancer, are considered, there is no genuinely safe level of alcohol consumption. The cardiovascular benefit in older studies is also complicated by confounding factors. Many non-drinkers in those datasets were former heavy drinkers or people who had stopped due to illness, making abstainers appear worse than they actually were. The honest current position: alcohol is not a health intervention. 9 factors, every single one modifiable, together explaining over 90% of the risk of the thing that kills more people than anything else. So why are we still losing this fight? 3 reasons stand out. First, healthcare is structured around treatment rather than prevention. Emergency medicine is extraordinary. We can save lives from heart attacks that would have been fatal 20 years ago. But we have almost no mechanism for catching and reversing the 10 years of silent vascular damage that preceded that event. The prevention window is long. We have years, sometimes decades, to intervene. But the system only activates at crisis point. Second, lifestyle change is structurally difficult. The food environment pushes people toward ultra-processed, calorie-dense products. Most modern occupations are sedentary by design. Chronic stress is endemic in contemporary life. Individual willpower exists inside a system that is not designed for prevention. Third, there is a widespread and damaging belief that cardiovascular disease is primarily genetic, that if it runs in your family, there is nothing you can do. The INTERHEART study looked at populations with very different genetic backgrounds and found the same 9 factors explaining the same proportion of risk everywhere. Genetics influences your baseline. It shifts your starting position. It does not determine the outcome. The 9 modifiable factors operate on top of whatever genetic background you carry. What can you actually do with this information? Know your numbers. Get a blood test that includes a proper lipid profile. Know your blood pressure. Buy a home monitor and use it weekly. Know your HbA1c and fasting glucose. If you cannot manage what you do not measure, you cannot protect what you have never assessed. Take smoking seriously. The risk reduction from quitting is substantial and begins almost immediately. If you smoke and want to stop, make it a genuine priority. Ask your doctor about the support tools available. The evidence for cessation support is strong. Do not dismiss the psychological component. Chronic stress is not merely uncomfortable. It shows up in the data as a measurable cardiovascular risk factor. Managing it is not optional if you are serious about long-term health. Move regularly. Walking for 10 to 15 minutes after each of your main meals addresses multiple cardiovascular risk factors simultaneously: glucose control, blood pressure, inflammation, and vascular function. The INTERHEART study gave us a remarkably clear map of what drives the disease that kills more people than anything else. What it tells us, unambiguously, is that the vast majority of heart attacks are preventable. The question is not whether we have the knowledge. We have had it for over 20 years. The question is whether we act on it. If this was useful, please subscribe to this channel and share it with someone you care about. I will see you in the next video.